Okay, welcome back, class. This is Unit 8, continuation, positioning, moving, and lifting residents. Positioning is helping residents into positions that promote comfort and health. Supine would be laying flat on the back, lateral is side lying, prone is lying on the abdomen, Fowlers or semi-Fowlers is 45 to 60 degrees, high Fowlers is 60 to 90 degrees, semi-Fowlers or low Fowlers is 30 to 45 degrees. Sims is on the left side with one leg drawn up. And I think I've given you pictures of those before. That's just a review. Transferring is moving a resident from one place to another, such as the bed to the wheelchair, to chair or wheelchair, or the wheelchair to the toilet or bedside commode. Some residents have a strong and a weaker involved or infected side. Nurse assistant must plan to move, this is important, nurse assistants move the stronger side first and then the weaker follows. What determines how we transfer a patient? Their size, their ability, their condition, their cognitive function, the equipment available. Activity is good medicine. You need to remember it prevents complications of bed rest. Effects of immobility, which is not being mobile, not getting out of bed, being bed rest. It can cause blood clots. A thrombus is a blood clot that is lodged, so you have like a deep vein thrombosis, which you say like lodged in your calf, and then you have an embolus, which is a blood clot that breaks free and is traveling. The embolus are more dangerous because they lodge into your heart or your brain and cause a heart attack or a stroke. Pneumonia you get from immobility, loss of muscle strength. Atrophy is actual muscle wasting, and contractures, or when it's a permanent shortening of the muscles where they draw in and almost eventually they kind of draw into almost a fetal position where everything just kind of contracts in. And poor circulation comes from immobility too. We need to be up and moving. Terms to know: atrophy, I just said those already. Weakening or wasting away of muscle. A contracture is a permanent or painful shortening of a muscle, tendon, or ligament. This is an example of a jerry chair. Jerry chairs recline and support the head and the neck. This is used for somebody who can't sit straight up in a wheelchair. They still can get up and be in a chair and not be laying flat. So this would lay flat beside the bed, and you transfer it to them, and then you sit it up. Once again, if the table is used on a jerry chair, this could be considered a restraint if the resident can't remove it themselves. Helping the resident to a sitting position. You can see he's got one hand under the resident's shoulder blades and the other should be under her thighs. The weight of the legs hanging down from the bed helps the resident. And so she's got grabbed around his shoulder. Moving the resident up in bed with a draw sheet. You're going to roll the draw sheet up to the resident's side. Grasp the palms at the resident's shoulders and hips. Those are your two heaviest points. Both people shift their weight to the back foot and move the resident. Make resident comfortable and roll the draw sheet. One important reason we use draw sheets is to avoid the shearing that can come from moving them in bed. If we were just to drag her body and not use the draw sheet, there would be shearing against her skin. Turning the resident away from you. Notice that on the top they're putting the foot over across, and then when you're going to roll them, pushing on their shoulders and their hip. And also, you also notice there the side rail towards the way she is rolling is up. So if they're able to help you, they can use the side rail to help roll. Log rolling is a little bit different. It takes two people. You have a pillow under their head, across their chest, and a pillow between their legs. Both workers should grasp the draw sheet from the far side and count on 3, turn as a unit. This is where everything must turn at the same time. For somebody who has some kind of spinal surgery, they may have an order to log roll only. So everything has to move at the same time to keep the spine in alignment. Dangling is help moving a person to sit on the side of the bed. You see he has his arm all the way around, wrapped around the top of her shoulder, and his arm underneath her knees. He's rolled the head of the bed up and going to assist her to dangle in the bed. You're going to transfer to a chair with a gait belt. The gait belt should be below the rib cage and above the waist. Make sure the breasts are not caught under the gait belt. This can be a problem with somebody with big breasts. You have to make sure and lift those up. Should be snug, leave enough room to insert flat fingers under the belt. Remember to bend at the knees. Have them push up on the bed. You can see her hands are down, and on the count of 3, she's going to push up, and you're going to stand at the same time. And once you're standing, you want them to stand straight up, and then before they pivot, they need to not be half up, half down. They need to be standing straight up. Transfer without a gait belt is somebody that just needs a little bit of support. You're doing the same thing. You're just wrapping your arms around their shoulder blades. This is the lateral position. All you guys have already been checked off pretty much on the sideline position. Just another visual of that. Dangling, when you get somebody up to dangling, you need to stay with them at all times. Check for dizziness. If the resident feels dizzy or faint, you need to help them lay back down and make sure she is secure, and then tell the nurse. Terms to know: orthostatic hypotension and postural hypotension. It is a sudden drop of blood pressure that occurs when a person changes position. So that is sometimes why they would get dizzy when they sit up, because their blood pressure drops. And sometimes that is a sign of dehydration. Sometimes there's other causes. But you wouldn't want to get somebody up who's dizzy when you sit them up to the side of the bed. You need to lay them back down, then tell the nurse. The gait belt is also referred to as a transfer belt. You place the belt over the resident's clothing, below the rib cage and not above the waist. That's a kind of a duplicate. You never put it on bare skin. Position the belt buckle slightly off center to the front or back. Leave enough room to insert 3 fingers into the belt, and insert fingers with the fingertips up. Safety. Always put on non-skid footwear on the resident and fasten securely. Anytime they will be standing. Never stand them up in bare feet. Correct use of a wheelchair. Remove the wheelchair footrest. Place the wheelchair near the head or the foot of the bed with the arm of the wheelchair almost touching the bed. Place on the resident's stronger or unaffected side. Always make sure before any transfer the bed and the wheelchair are both locked. Positioning in a wheelchair. The back and the buttocks should be against the back of the chair. They shouldn't be sliding down. Feet are flat on the floor or footrest of the wheelchair. Back of knees and calves slightly away from the edge of the seat, and support affected arms with pillows. So if they have a weak side, you would want to put a pillow under that arm. If you're taking someone to the toilet, this is how you would line them up. Most of our bathrooms, it shows there with the foot pedals on. I would take the foot pedals off before you go in, because there's just not room in the bathrooms, and that gets them closer to the bar where they can stand up better. This is just transferring somebody from the bed to a stretcher. So the stretcher is laid flat at the same level as the bed. You got 2 people pulling towards the stretcher and 1 on the other side. And he's got his hands crossed across his chest. A hover mattress, that's another way to do a transfer. You'll get training on that if you use that in your facility. Stretcher safety. Safety straps are used. The stretcher side rails are kept up during transport. The stretcher is moved feet first. That's usually always a test question, so they can see where they're going. And the staff member at the head of the stretcher can watch the person's breathing and color. Never leave person alone on the stretcher. This is a picture of a mechanical lift. Most facilities have them. This one looks like it's a one that's a pump instead of electric. Each facility you work at will give you, they'll have different kinds, and you'll have training on that. Mechanical lifts important things to remember is that you never do a mechanical lift with one person. It always takes 2 people. You have to know the weight limit of your mechanical lift. With resident's arms folded across his chest, attach the straps. Make sure that one person supports and guides the body to help prevent injury. So somebody's going to be hanging onto the sling and the other person's going to be pumping them up to move them. Walking aids, also called ambulatory devices, are a type of aid ordered. The type of aid ordered will depend on the person's condition, the amount of support needed, and the type of disability. Crutches. When a resident uses crutches, the CNA should stay on the resident's weaker side. Important. Residents should be fitted for crutches and taught how to use correctly by a physical therapist. Weight should always be on the hands and arms and not on the underarm. Canes are used for weakness on one side of the body. They help provide balance and support. They are single tip and 4-point or quad canes are common. That's a picture of a quad cane right there. A cane is held on the strong side of the body. Make a note of that. A walker is a 4-point walking aid. It gives more support than a cane. There are many kinds of walkers. Some have baskets, pouches, or trays attached to the walker. All 4 feet of the walker should be on the ground before they step forward. Safety. Good body mechanics. Get help when you need it. Identify the correct resident. Let resident know what you're doing or going to do. Always move on the count of 3. Range of motion. We're going to mention this. We'll talk about that more when we get to rehab. But there are 3 types: active range of motion, active assistive range of motion, and passive range of motion. Active means you're just telling them what to do and the resident does it himself. Active is you can tell him what to do and you're going to assist. Passive is somebody who is on bed rest that does not move anything on their own and you are doing the movements from them. This is used like to prevent atrophy and contractures. Range of motion movements. Abduction is away from the midline. Adduction is toward the midline. Extension would be straightening a body part. Flexion is bending a body part. Dorsiflexion is bending backwards. Plantar flexion is bending forward. That's usually pertaining to your foot. Rotation is turning the joint. Pronation is turning downward. Supination is turning upward. Opposition is touching the thumb to the other fingers. So those are basic movements of range of motion, and we will talk more about those, like I said, when we get to rehab. That's just an introduction to range of motion movements. And that's all I've got. Thank you.